Assalamu alaikum wa rahmatullahi wa barakatuh. Very good evening. Welcome to another edition of Health and Wellness. I'm Salim. Stay with me for the next just under an hour up until 9 o'clock, inshallah, where we once again do Movember Men's Health Part 2. We have in studio a specialist urologist, Dr. Salim Choonara, in studio, and a special edition for men's health because there's been so much feedback, so many questions and queries around men's health, around the conditions that we had in our previous show about a week or two back at the beginning of the month, and the interest is there, which means great stuff, guys. Alhamdulillah. Sometimes it's the ladies that's doing the inquiries, but we have had some calls from men as well, attentive to their men's health. So today we'll be discussing prostate and bladder, a little bit more around that. So please don't forget to interact with us. The show is live. So we have the doctor in studio with us, Dr. Salim, to answer your questions. 1 in every 8 men is diagnosed with prostate cancer, and that happens within his lifetime. Prostate cancer is more likely to develop in older men and African black men as well. So the stats are quite high here in South Africa as well. About 6 cases in 10 are diagnosed in men who are over 65 and older, and it is more rare in men under 40, but it does happen. The average age of men at diagnosis is about 60, 66. We're also chatting about urinary health, which is definitely needs attention because it does also happen with men, and it presents sometimes as young as 40 and 50. But to get into the bladder and prostate, let's now welcome Dr. Salim Choonara. Assalamu alaikum, Dr. Salim. Welcome back.
Wa alaikum salam. Thanks for having me again.
Shukr, alhamdulillah. I know I sent you questions, but now we can have the questions done live in studio if our viewers do have them. But we've spoken quite a bit about men's health, and just to give some feedback on where we were at last time and just to run down to where we're going to today.
Fantastic. So I think our last program we touched a bit on things like screening. We mentioned about when should people go for screening, who should be screening. We touched on aspects about family history of prostate cancer in particular, maybe as early as 40 or 45, depending if you've had a significant family risk of cancer. That obviously in prostate cancer in males, but I would extend that also just for which we didn't mention the previous time, even if it includes cancers in the females, maybe females in your family. But cancers in early age, there are certain genetic markers that we use to sort of, show some link between certain cancers that occur in females and males. So I think the take-home message that if you have a family history of cancers, perhaps in your case, you need to then check early, maybe 40, 45, have a baseline test. And then your clinician will advise you from there onwards, whether you need to come every year, every second year, depending what the situation was like. Okay. So we did touch upon that. I thought for this discussion, we focus a little bit more on men that have an elevated PSA.
Okay.
Because then we just want to maybe explain to the viewers what is the progression, what is the plan from there. Once you have this elevated PSA, what are the next steps that come into play that either lead to a diagnosis of prostate cancer or just an enlarged prostate, or is this just an infection in the prostate? Because often when patients see the high PSA, especially those that have been reading around PSA, the first thing that they think about is that I've got cancer.
Yeah.
Like that's the first thing that crosses their mind.
So exactly, for anybody that has missed and they're watching right now, what is PSA?
So PSA is, it stands for prostate-specific antigen, PSA, right? Essentially, it's a protein which is produced by the prostate gland. Now, again, for the viewers, the prostate gland is only found in males, right? Just below the bladder. It's like a walnut-sized type of gland. And what we know about the PSA is that it's only produced by the prostate. So in other words, we can know if there's an elevation of the PSA, some abnormality there, we're homing in onto the prostate. What it means is now, hopefully we'll discuss it in this program, you know what I mean? But so I think that's the first important thing to understand what it is.
So the reason why you're going for PSA is just a general test, or is it something that's concerning?
Yeah. So remember, the screening aspect is happening in patients that are not otherwise well and healthy. They don't have symptoms, but we're saying just give a baseline, check kind of where your PSA sits. Okay. You may have, for example, someone with a family history of cancer at 45 may come in suddenly, find the PSA is elevated. Remember, it may not correspond to any symptoms because they may be absolutely fine at that age. They may have no symptoms. So the idea of screening is to just identify those individuals that may be at high risk. That's slightly different to somebody walking in our rooms at age, say maybe they're already 60 or whatever, they got some urinary symptoms, difficulty urinating, problems passing urine, issues around urinating. In the process of examining them, we'll do a PSA as part of assessing the prostate. Okay. That level will now determine which way we're going to go. Because remember, the screening part is that you're just doing a test. If it's all okay, we say, okay, we'll see you again in 2 years' time. It's slightly different for the patients in our rooms at the time coming with a complaint. That PSA is now going to make us act upon it right there and there, which way we're going to go, you know. Because remember, the comprehensive assessment that we do in our rooms includes ultrasound as well. So most urologists, probably all urologists, are trained in ultrasound. So when we see our patients, apart from taking a good history, getting the symptoms, examining the patient, examining the prostate, the digital rectal exam, doing the ultrasound, checking the flow rate, how they're urinating. So by the end of that assessment, we have a fair idea where we're going with this prostate issue, and then we add to that the blood test to see what does the PSA show, you know. And then based on that level, we're going to decide, okay, does this patient have a level have a PSA value that's concerning? If that is the case, and we don't think, for example, it's related to infection, because let's assume someone got a PSA of, say, 10, for example.
Okay. So of course it's raised now.
It's raised, right? But they may have other symptoms. You test the urine, you may find there's blood in the urine, there may be some signs of suggestive of an infection. So now in that case, you now need to put the whole picture together and say, this patient's PSA is elevated likely because of infection. So we wouldn't just simply say, no, we need to biopsy you now, we need to go remove your prostate. No, we're going to say, okay, let's give you a course of antibiotics. And the thing about, while we're on that point about antibiotics for prostate, it's not like you take something for your throat, you know, or ear infection. It's a 5-day, 7-day course, not like that.
Okay.
With the prostate, you need an extended course of antibiotics, ranging between 4 to 6 weeks, depending on the choice of antibiotic that one needs to use. So that understanding, you know, patients are feeling better after like 10 days, and then they leave it. And that's not necessarily a good thing. We must complete the course, okay?
So it's a raised PSA with certain symptoms.
Yes.
Would now call for an antibiotic, a course of antibiotic, not other tests.
Yeah, if it's related, if we think that after having done that whole assessment, right, because you've done the ultrasound, we'd have tested the urine in the rooms, you would get a gauge from the burning on urinating, difficulty urinating, running very often to the toilet. If this urine is suggestive of an infection, then we'll treat that patient first with a course of antibiotics and then repeat the PSA. So for example, maybe the PSA was 10, right? And then we treated them with for an infection, what we call a prostatitis, all right? And then we may do a PSA again after about 6 weeks or so, and the PSA may come down. Nothing for us to do. It was an infection. We treated them, story over. We can put an end to that.
Okay.
You see what I'm saying?
So raised a PSA, you've mentioned the 10 stats. Whatever's higher than 10, what is the normal PSA?
Yeah, so effectively, I just use 10 as an arbitrary value, but the range generally we're looking at, so we look at the age-specific reference ranges. So the younger individuals, we're using a lower level, let's say about 3.5 to 4. If it's below that, we regard it as relatively normal. For an older person, maybe someone over the age of 70, 65, 70, 75, we may allow the PSA to go even up as high as 4 to 4.5.
Okay.
But the point here about the PSA, however, is not the absolute value. It's the trend over time.
All right.
For example, you could have a PSA of 0. A man could have a PSA of 0.5 all his life. Okay, the lab reference range is 3.5. Let's assume in 1 year they come and their PSA is 2.5. So just as an example, all along is 0.5, 0.5. Suddenly there's this jump from 0.5 to 2.5. It's still kind of below the reference range for the lab, which appears as normal. But that change for that individual may be significant. You see what I'm saying? So I think the trend over time is a better overall and maybe holistic picture of the prostate rather than a snapshot in time.
Yeah, we spoke about that before. So would it a year gap? You mentioned after the antibiotics, so it's like about a month or 2 gap.
Yeah.
But if your PSA is okay, you check it again in a year's time?
Absolutely.
Okay.
So especially somebody over the age of 50, between 50 and 55, we usually see them like how women go for yearly checkups. Exactly.
Yes.
That. They're probably feeling absolutely fine, but they're coming for the yearly checkups.
Right.
Yeah.
So the plan ahead for the raised PSA in connection with just the antibiotics, so there's a possible infection. What other interventions are there for other raised PSA?
Yeah. So I think that's a common one. And again, the age group is also a determinant factor there. In the younger individuals under age 40, 45, it's likely to be a prostatitis. In an older individual that comes with a high PSA, the likelihood of infection is probably less likely. Okay. So we've dealt with the infection side of it. So what are the other possibilities? It could just be a very big prostate, and that could be assessed by way of their symptoms. And like I explained, we do what I call a uroflow, or a flow meter. So the patient pees into urinates into like a cup, that measures the speed at which the urine is coming out from. So we can really assess whether this patient has difficulty urinating, peeing freely, or is there a sort of stop-start phenomenon or a difficulty urinating, right? That could suggest a large prostate. Very important to that assessment is the rectal exam. Because remember, if you examine the patient and the prostate is found to be abnormal, hard, as I said the last time, almost like the palm of your hand being the standard. So it's hard, it's bumpy, it's nodular. even before you look at the PSA, already in that individual that has a hard nodular prostate, you're already suspicious that this could potentially be a malignancy, or it will need further investigation by way of a prostate biopsy. Now remember, even if that individual's got a hard prostate, but if there's an infection there, you want to also treat that infection and then plan the biopsy in that patient. Because you wouldn't want to simply take a patient for a biopsy, but they've got an acute infection in the urine. You know, you want to treat that first and then approach that.
So it's not
that
just
situation.
antibiotics, it's then also going for the biopsy.
Exactly, but now remember, now you've been highlighted because there's other problems there. You know what I'm saying? That patient, you figured out the prostate is abnormal, the PSA may be high. So there's other symptoms, other signs you've picked up in your assessment that you know, no, this patient can't go and see you again in a year's time. He needs to have the biopsy because there was some abnormality on the prostate itself. Do you know what I'm saying?
Let's talk about the biopsy after the short break, what that all entails. We have Dr. Salim Choonara with us. Remember, we are taking your questions, comments and queries with regards to men's health, their prostate and their bladder, live in studio. Back in a moment. Stay with us. Welcome back. Assalamu alaikum wa rahmatullah. Very good evening. Remember, you can tell your family, friends that we're chatting about men's health with specialist urologist Dr. Salim Choonara. If they're listening to us across the lands and over the beautiful seas, they can stream in live right now on www.hilaal.tv and also send through your questions on our WhatsApp and call in live number. If you have any men's health questions, we're chatting prostate and bladder. Welcome back, Dr. Choonara. We left with the prostate biopsy, and I'm sure that's quite invasive. Let's tell us how the men need to prepare for that and how that is done.
Yeah, so that would be regarded as an invasive
and why it was needed, because you did an internal
exam. So as I said, like by the end of that examination, you've done a physical examination, you've done an ultrasound, you also got the blood test ahead of you or in front of you. And in some cases, we may also do what we call an MRI scan of the pelvic area of the prostate to highlight certain areas that we know the right side, the left side may be suspicious. So it also helps us in terms of which area to target when we do our biopsy. So that we know, okay, that was a suspicious area. That's not routinely done, but it's something which is definitely practiced now, I think, in most parts of the world, internationally, overseas, more first world, to do MRIs before every single biopsy. Yeah, I might practice it, but a case by case. Medically, haven't caught on entirely to that as well, right? Yeah. But nonetheless, so it's an invasive procedure. It can be done under local, but I think most urologists do it in theatre under anesthesia. It's really not a major anesthesia. It's a very light anesthetic, a bit of mild sedation as well. You can get away with doing a biopsy. So what it involves is most individuals do it with an ultrasound. So an ultrasound guided biopsy. So in other words, we have an ultrasound probe. Very much females will know about when they go see the gynae, that long probe that they used to do a vaginal ultrasound. Something very similar we used to place into the rectum. So that the prostate is now shown up on the screen. And then on that ultrasound device, there's a guide through which the needle will pass, which is then calibrated to the screen. So we can move our ultrasound. If we see something suspicious on the ultrasound, we can now guide the needle to that area and sample that area. So how we...
I'm glad you actually mentioned that, because just doing some Google search today, I actually saw a picture of that and how they do it in theatre. And the prostate is showing with this probe. And I'm thinking, why are they using the long probe? So that's...
So you can now... So you have an image of the prostate. So you guide in your biopsy. Now remember, you've had a lot of information before. Perhaps you examine the patient. You know there was a bump or a nodule on the right-hand side, for example. So you know this beforehand. So obviously you're going to focus on the right, look at it, see what looks suspicious. Guide the needle to where you want to go. It's a special device. It takes out like a tiny core of tissue, almost like a strand of tissue, maybe about 2 centimeters in length, 1.5 to 2 centimeters in length. With every bite of the prostate, you get in these, what we call prostate core biopsies coming out. So we do right and left, commonly it's done that way. You can also do like a grid kind of biopsy, where we map up the prostate in terms of different quadrants. So you have, for example, like say A1, B5, C2, C9, whatever it may be. Then the idea of that is, when you plan something very, very localized for the prostate. But I must say, most commonly, most doctors don't do that. It's expensive. You need special equipment for that as well. So by and large, I think most urologists do it under ultrasound. All right. And then, the thing is, there is a risk for infection because it's an invasive procedure. So we've got to cover the individual before with antibiotics, and they have to take a course of antibiotics even after that. There can be blood in the stool, blood in the urine, as well as blood in the semen because of the needle going through the prostate. I
So
would
that's the
say
side effects.
it can happen. It may last for about a few days, maybe a week or two.
Okay.
But we're aware of this, so patients are on medication for that. Okay. By and large, I would say it's post-procedure. It's mild to moderate pain, maybe for the first 24 hours. Thereafter, it's a level of discomfort, and the patients are fine. Most individuals, majority of individuals, have a biopsy and can go home the same day.
Okay.
Unless there's some bleeding that one is a bit concerned about, we may keep them overnight
Okay.
and watch them. The other thing about
So if you book it in the morning,
Yeah.
it takes about an hour.
even less, with the
Okay.
anesthetic time, maybe about 10, 15 minutes. The biopsy is about 10, 15 minutes. What I tend to do also, when we do it in theater, when we're doing a prostate biopsy, at the same time, we also do what they call a cystoscopy. We put a camera basically into the penis,
Okay.
into the urethra, and we go in and we can see the core of the prostate on the inside.
Sure.
And then we can also see the bladder. And so it kind of gives us a little bit more information about what the situation, what the anatomical situation is of the
When
prostate
you're seeing it, yeah.
internally. Just helps us a bit with some information as well,
Wow.
So I tend to do that at the same time. Doesn't really add much to the procedure. Literally,
Okay.
it's another maybe 2-3 minutes extra, but a lot of valuable information,
So that's the complete biopsy, prostate biopsy. You do it from the front and the back.
Yeah, so that's a good point. So sometimes what happens is, you see, majority of cancers tend to occur peripherally, right?
Okay.
So when we're doing the biopsy through the rectum, in other words, the rectal probe, and we can see the prostate, we are sampling the prostate in its periphery.
Okay.
When we put the camera through the penis and we're looking inside, okay, it's now the central core of the prostate.
Oh, okay.
So there are certain times when we do take some samples from there as well.
All right.
So we'll have a central core biopsy and the peripheral
How
biopsy.
big is the prostate?
It can vary, and from anything from 40, 60, 80, 100, 120, 200 grams. It can vary, so it depends on the age of the individual.
Oh my goodness.
So the prostate does grow with time,
And then the signs of an enlarged prostate happen from age 50, and is it always a concern?
Yeah, so that's the common situation, where, again, that whole issue about, if you think about a core of an apple, if you were to remove the core. But if there's a growth of the prostate on the inside, because remember, the urine comes from the bladder,
Yeah.
passes through the tube. The
Okay.
prostate encloses that area, what we call the prostatic urethra. As the prostate enlarges, what it does is it narrows the diameter of that opening. So naturally, it's like a plumbing situation, so they're going to have difficulty urinating because it's going through a smaller passage. That's what may prompt the individual to go and see the clinician. Remember, even if your PSA was 20, for example, there's no symptoms that says to you, hey, my PSA is 20. You're not aware of that. That's a blood test. But what may prompt the individual to go seek medical attention is the symptoms they're experiencing.
Okay.
By way of difficulty urinating, burning, discomfort, whatever it may be, something that's interfering with the urination, or the urinary system.
But that's also possibly UTI symptoms.
That's what I said earlier. So you have to have a comprehensive examination. At the end of that examination, you're going to know, well, this individual, is this prostate something of concern? Or it's just an infection. Let me just treat the infection and see the patient again. But at least by the end of that examination, assessment, the clinician will have a good idea what this individual's risk is for cancer or no cancer. Is there enough evidence, enough information
Yeah.
to make a biopsy, to allow a biopsy to be indicated, yes or no? You're going to have that information. And if you
Yeah.
don't know, then there's other tests you'll employ, scans, MRIs, etc., as explained,
Okay.
which will help to guide you as well.
So the enlarged prostate and medical therapy, what other roles does medical therapy play in the enlarged prostate?
So
Besides the
sure.
biopsy,
So again, let's say the index patient, somebody with some symptoms of urination, difficulty urinating, waking up at night, for example, did the whole examination, large prostate, but nice, soft and smooth, PSA normal, maybe like 2 or 2.5. Right? So we know this patient, his symptoms are related to a large prostate, but there's no concern about cancer. All the parameters are normal. We'll give them medication to try to assist the urination. So not antibiotics, but it will be medication. Patients will note words like Flomax, Uromax, Cardura, Cardugen. Most males that are on this medication will be familiar with those terms, okay? But the point about it is that it's medical therapy. Medical therapy to try to assist that individual to urinate better. So the medication helps to sort of relax the bladder neck and, open its space up a little bit so that the urination becomes more freer. You see what I'm saying? So those individuals, we put them on medication and see them again 6 months to a year and see how they're doing.
Okay.
Eventually they may get to a point where medical therapy may fail. In which case then we'll go to the other options like the surgical options. But patients can stay on medicine for a long time, 2-3 years even, maybe even longer, as long as their symptoms are controlled.
Okay, let's talk about the big C word. So if cancer is present and that's the outcome of the biopsy,
Yes.
what do they do now?
Okay. So not just to prostate cancer, any
Okay.
cancer, for example. If
Yeah.
you are diagnosed with cancer,
Mm.
in this case it's prostate, the next question the clinician asks themselves is, has this cancer spread beyond the confines of the gland, or is it just only in the prostate? Okay.
Mhm.
And to answer that question, we do further investigations, such as X-rays of the chest. We do MRIs of the prostate. When we do a bone scan, commonly those will be the three.
Okay.
So why do we do that? Because we want to know if there's a cancer in the prostate, is there any evidence that it has
Of where
spread
it came
outside
from.
of the prostate?
Yeah,
Has it gone somewhere else?
Mm.
So a cancer is localized to its origin, like in this case the prostate. If it's localized to the prostate, it's a better outcome, you know, because it has not spread. So our efforts, our treatment, our aim is to eradicate the cancer where it is sourced from, which in this case is the prostate.
Okay.
And again, like I said, you know, that determines now how you're going to treat this patient. Localized prostate cancer, you have many options available, surgical options, and now we have the robots available in South Africa. It's been here for years,
Brilliant.
and it's fantastic. I mean, it has changed the way surgery for the prostate is performed. You know, it's a really amazing technology. And then you have radiation treatment. People will be aware of things like brachytherapy, which is where we place these very tiny radioactive pellets or seeds within the prostate. That's
Okay.
very localized radiation treatment. Then you have external radiation,
Yeah.
and you know, hormonal therapy, which can take a form of an injection or tablets.
Mm.
The one thing, you know, just to maybe to give the viewer something to take home about treatment of prostate cancer, there's a revolution how we treat prostate cancer nowadays. The cure rates for localized prostate cancer exceed 94%. You know, for patients to die of prostate cancer nowadays is very rare.
Yeah.
They may die of something else. You know, picked up early, prostate cancer can be managed exceptionally well.
I saw some of that stats reading. It's
Exceptionally
actually 100%.
It's
in
phenomenal.
fact, and only probably when you get to stage 4 is a probability of
So
30%.
That's right. So like
Yeah.
almost like the disease of extremes, you know. Picked up early, and that's why programs like this is to enlighten individuals to seek attention when there's a problem. Because the prostate cancer picked up early has got it's got excellent outcomes. But picked up later, if it is spread to the bone, spread outside of the prostate, lymph glands, etc., the outcomes are less effective.
Yeah.
You know.
So let's not ignore those little bit of ailments if you can possibly pick them up.
Yeah.
We have Dr. Salim Choonara in studio with us. Please do note we're taking your comments, questions and queries on our WhatsApp line, and you can also call us live in studio. We'll continue the treatment options and move on to the bladder possibly just after the short break. Don't go anywhere. Welcome back. Assalamu alaikum. A very good evening to you. Hope you are well, warm and cozy wherever you are, hot and bothered. So taking a nice warm cup of tea. In fact, that does cool you down when you are hot and bothered. Never mind the ice. I'm Salim. Stay with us as we deal with the questions on prostate and bladder. We will do bladder in just a minute. But before we do that, we continue the conversation on prostate cancer, the biopsy, the treatment options with the specialist urologist in studio, Dr. Salim Choonara. So before we go any further, Dr. Salim, we have looked at some of the treatments and we can expound on that as well. But the question that has come in with somebody with prostate cancer, 5 years ago he was diagnosed. There are some questions we just need to check in with him. Ishmael says, I had a prostatectomy done 2 years ago. My PSA went up to 20 and the doctor was confused, went for a PET scan and found metastasis, I think it is, in the hip. Did radiation therapy, which brought the PSA to 2. Repeated PET scan 6 months later and discovered that the cancer has spread to my spine and another spot on the hip. I'm currently on Zoladex injections, which has brought my PSA down to 0.1. I want to stop the injections, he says, for 3 months. Do you think it's a good idea? What's my prognosis? Should I start with radiation therapy? Ishmael says. Shukran, Ishmael, for your question. Very, very interesting as well. Please do keep that questions coming. And it's so informative as well that men are reaching out, and women as well, to show interest in the men in their life for their health.
It's an excellent
So
question. Very loaded question as well. So the last point about what's my prognosis like and should I leave out the injection? I'm going to get to that in a second.
Okay.
So whenever we think about prognosis, especially in prostate cancer, we always go back to the initial diagnosis. Why is that important?
All right. 5 years ago.
Yeah, because we want to know what kind of cancer we were dealing with at the time. Earlier on I mentioned to you that if you've got a cancer, we do some scans, MRIs, bone scans, whatever it may be, to decipher and identify, is there any evidence? Before we before we treat that patient,
Yeah.
is there any evidence that there's something outside of the prostate?
Okay.
We're not kind of sure what Ismail's situation was in that situation. He went for the robotics, so there's some specific we don't know.
Yeah.
But I just want to highlight that point, that information about cancer being localized or having spread is identified usually prior to taking on a treatment strategy, right? It can happen though. You may have surgery now, 2 years down the line, you have some evidence of cancer. Also, what's lacking in the information there, when they remove the prostate, remember we spoke about the robot, amazing treatment, fully support. It's an excellent initial way of removing the prostate. And when you take the whole prostate out, there's also lymph nodes that we remove at the same time.
Okay.
When that specimen goes to the lab, there's some information we gather. Are the lymph nodes positive? Are the margins that we've removed, are they positive or negative?
Okay.
It also helps us decide, you know what, does this patient then require radiation immediately after surgery? Why is that important? Because if we think maybe we left some microscopic disease behind, we want to attend to it early, not wait for something to happen.
Yeah.
Okay. So I just want to make those
Very
2 points, right?
interesting, yeah.
But the issue about prognosis and about stopping the injection, the simple answer is no. Why? Because already just what Ismail is saying, he's had surgery, they found it in the hip, they did radiation, they found it in the spine. Now he's on hormonal therapy and he's now got a very good response. His PSA is 0.1.
Yeah.
That's fantastic. The injection is a systemic kind of treatment. So remember, it's working throughout the body. Wherever there may be some foci, some nests of cancer cells, it's going to keep that under bay. It's not going to unfortunately cure the cancer, but it's going to keep it under control. That's why it's important for him to maintain the hormonal therapy, because that is what is keeping it under control.
Okay.
You see, so you stop it, you're allowing again the cancer to sort of perhaps progress, perhaps sort of reactivate, and that may not be a very, very good idea. I'm very curious to know what his age was, you know, in some of the
Yes,
specifics
yes, Ishmael.
around
So if you
cancer.
can actually just call us, or sorry, just WhatsApp us to tell us what your age is,
Yeah.
it'd be very interesting to connect.
However, the
it to this
prognosis,
question.
again, it brings us to that point we made earlier. When it comes to prostate cancer, and this is an absolute reality, absolute fact, that there's many, many treatment options available to manage prostate cancer, whether it be localized and even whether it has spread. Enough to the sense that patients can have a very, very good and reasonable quality of life, whether it be localized or advanced cancer. But there is many options available for treatment. You know, whether it involves things like hormonal therapy he's talking about, which is an injection every 3 months, whether it involves things like chemotherapy, whether it involves things like smart drugs, whether it involves like immunotherapy, whatever it may be. There are many, many, many options available that we can use to try to not necessarily cure his cancer. In Ishmael's case, because it's already spread in so many places,
Yeah.
we can't make the claim that we can cure this cancer, but alhamdulillah, inshallah, we can try to keep it under control. That's the reason why I'm saying you should not leave the injection. You know.
So what would you say the difference is for the hormonal compared to the radiation therapy?
So the radiation therapy is much more specific therapy. You know, so that same example I used earlier. Let's assume he had surgery, and we send it to the pathologist, and the pathologist says the lymph nodes are positive or the margins of the gland are positive, which may suggest where the prostate was, we may have left some microscopic disease.
Okay.
We would now use radiation therapy after the surgery to radiate the bed where the prostate was, or the lymph node chain, just in case there's some cancer there, at least we can eradicate it.
Yeah.
To prevent the likelihood that we may deal with some evidence of spread down the line. That would be one way we could use radiation.
Okay.
But hormonal therapy has got an interesting role. It has its role in both localized prostate cancer and advanced prostate cancer. Because what the hormonal agent does, it's literally medical castration. That's what it is. Before we had the injection, you know, men would cringe to hear this, but we literally would remove the testicles, literally cut it out. Before the advent of these injections, that was the treatment.
Sure.
We would remove both the testicles. Why? To take away the testosterone. But what these hormonal agents do now, it's a medical castration. It's literally shutting down the prostate. Shutting down the testicles, like as if they don't exist. There's
So maybe that's why he's thinking of stopping the hormone.
I know, I was going to get to that point now. The side effects are probably what's bothering him.
Yeah.
The hot flushes, what we call andropause, very much what women go through menopause. Andropause, hot flushes, lethargy, bone weakness, emotional lability. You know, so, and patients don't like it. And obviously the sexual effects, the erectile dysfunction, all the other aspects that come with that.
Sure. So he's sitting with those symptoms, and how can he manage it?
So hot flushes we can manage quite well. There's tablets we can use to balance it off. When it comes to things like sexual effects, erectile dysfunction, there are tablets one can use, there are injections that one can use. The bone pain, the bodily aches, one has to overcome them, you know, weight training, you know, eating healthily, exercising, muscle stretching, biokinetics, to try to help, improve your muscle strength if that's what he's experiencing.
Okay.
But I know the thing. I mean, most patients on hormonal injections, they don't like it.
Yeah.
It's not a very nice thing.
No, not at all. Doesn't sound nice. And now they can realize what us women go through. Okay, so Faiz says earlier, and we spoke about the enlarged prostate, another question. Salam, I'd like to know what is the purpose of the scraping of the prostate, if enlarged? Also, can a man still reproduce if prostate is removed? Reproduce sperm?
Yeah, or
Okay.
fertility as well.
Okay.
So
So it sounds like Faiz probably still young.
well, I would say if he's had a scraping, he's probably, I'm sure, over 60. I'm sure.
Oh, okay.
We spoke about initially. We said about medical therapy. The index patient comes in there, some difficulty urinating. First line of therapy would be medical therapy to help improve their symptoms. It may happen a couple of years down the line. Their prostate getting bigger with time. Eventually, they lose the effect of the medication. So if they're having some really bothersome symptoms, the next step would be some kind of way of opening up that cavity, the outflow tract. One way of doing that is by a scraping.
Okay.
So the same thing I told you about earlier, we put the camera through the penis, we can go in, now we can see the prostate. So you can
that's
see
also
this.
a way of biopsy.
Well, but in this case, it wouldn't be biopsy. In this case, it would be now resecting whatever's enlargement. Because
Okay.
remember, what happens is you put the camera in there and you see this prostate.
Yeah.
And it's probably almost like the right and the left lobes right up against each other. So there's hardly even any space to where the urine can come from.
Okay.
Via that channel, so we don't make any cuts on the outside. Via the scope, the special devices that we use, special instrumentation we can use, we can now almost debulk the prostate. So if it was like this, cut either side and eventually you make the space wider. You see what I'm saying? So you're little resecting, almost like a hot knife to butter, if you don't think of it like that.
Okay.
Taking out pieces of the prostate to the point that you've created a sufficient channel by way through which the urine can now pass more freer.
Okay.
That strategy of scraping or let's say cutting through the prostate, what we call a TURP, transurethral resection of the prostate.
Oh, I saw you sent me those
Yes.
notes.
Now, we can use different methods.
Yeah, you
There's
can.
lasers available now. There's things like microwave therapy. There's a surgical cut where you can make it with electrical kind of current. So there's a whole lot of possibilities, that one can use to accomplish that task of debulking the prostate to make the space wider.
All right. So that's what it is. What was his diagnosis then?
Well, I think he said he had a resection, so it was most likely an enlarged prostate. And he just wanted to widen the channel.
Yes, it just said enlarged.
Yeah, that probably
Okay.
makes sense.
And the question about reproducing?
Yeah. So because once you cut the prostate, what happens is that the semen volume comes down. And men have what they call retrograde ejaculation. What it means, instead of the sperm coming forward and going and exiting through the penis, it goes back into the bladder. That's how it can impair their fertility. But most cases in men that are over 65,
I've seen men get married at 70 and still produce kids. Sure, that's amazing.
But so they must understand that that will happen, that they'll have this retrograde ejaculation. In fact, that phenomenon of retrograde ejaculation already happens when they're on medication.
Okay.
Like the Flomax.
And that's not
Uromax.
dangerous at all?
No, it's not dangerous. What happens is the sperm will just come out in the urine.
Oh, I see.
That's all it happens. We don't
So
harm
it's
them in
stored
any
in
way.
the bladder and then comes
Yeah,
out.
yeah.
Okay, we take more of your questions this after the short break. Stay with us as we discuss bladder and prostate. We're definitely going to talk about bladder in the next segment. Alhamdulillah, the questions has been very interesting for both, our viewers and myself to learn about this condition, how the screening is so important the minute you suspect any sort of symptoms or that it is possibly in your family. But we talk more on this topic with Dr. Salim, Choonara, urologist in studio live. Back in a moment. Don't go anywhere. Stay with us. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. Our last segment and our last few minutes of the show. We are hopefully going to quickly squeeze in some bladder information. But just before we do that, let's, of course, chat to our doctor, specialist urologist, Dr. Salim Choonara. Doc, listening to all these issues around the prostate, I'm just trying to wrap my head around some of the diagnosis of the cancer patients, some information, myths and misconceptions when it comes to prostate cancer that men and women should know about. And I know you, as discussed now in the break, you deal with even female bladder issues as well. But and that, I think we need to do a show completely on its own. But with regards to the cancer diagnosis, the intervention, the treatment, is surgery always an option? And what right does the patient have to possibly seek a second opinion?
Absolutely. That's why I made a point about saying that there's so many options available. Surgery is one option. I think when patients are sitting in front of their clinician, what's important is that they must be given all the options.
Okay.
And then have an opportunity to go home, digest the information, come back again. And they may have further questions. And that's what we tend to do in practice. We call them back again, maybe with the family this time, or maybe there's a GP in the family wants to know more information, whatever it may be. So I think they must understand all the options available to them, and then we make a decision together, which is the best one. Because what patients do they say, okay, doc, but if this was your father or this was you, for example, like, what would you do? So they do take into account your opinion, but they must understand it completely. So I think that's very important. The issue about second opinion, absolutely, it's a right of every individual, And at the end of the day, amongst Muslims, our understanding is very simple. Medicine and the way we treat patients is also your rizq and your rosy, and you say, it's what Allah has planned for you. And sometimes, if the match is not there between doctor and patient,
you feel it.
You feel it. Yeah. You just know when there's a click, when it's working out. You know how you feel inside of you. That's the important thing. Yeah. If you got that kind of connection, you're in the right place, Sure. But then too, second opinion is nothing wrong. Let patients go out. Remember, it's a peer review, If I tell you something as a urologist, I mustn't be able to say this in a vacuum. If the urologist down the road is going to say, hey, but you know what, he didn't tell you about 10 other things. That's problematic, no? It shouldn't be that way. If the person is going to go for a second opinion, I must be confident that I told you the right thing, So it's very important, I think.
I'm so glad you brought that up, and often we don't realize, us as laymen, we trust, and in our religion, in fact, we are more prone to take the medical advice of the doctor above the imam or the sheikh, because they have to check in with the when it does come to medically related issues. Yeah. So for us to trust our medical doctor to that extent, that our religion also plays a role in it.
I think the trust is, even in surgery, it goes even beyond that. When you allow someone to take you to theatre, you are asleep. Just think about that concept for a second. Like, what kind of trust you must give to the doctor's treatment. So, I mean, trust it's only about trust. Yeah. It's only about trust.
So any myths and misconceptions? I think what I'm going to do is, we're not going to talk about the bladder. I'm just going to do an introduction on the bladder. Our time is running out. Yeah. But let's just do an introduction on the bladder. But before we do that, any myths, misconception, lifestyle changes that people can do now, besides knowing your PSA, when to go for your PSA and screening and stuff like that. But lifestyle changes, if you know that it's within your family, you've got it, everybody can play a role in 100%. That to prevent prostate cancer.
I can summarize it in one word: obesity. Because now we understand that obesity, being overweight, being unhealthy lifestyle, has a risk for cancer. Not just prostate, any cancer. So I think if you know that you have a family history of cancer, the one thing about you that, first of all, don't be negative, be positive, because you've been proactive. But live a healthy lifestyle, eat healthily, exercise regularly, and seek information about it, talk about it. And that's where you're going to be channeled into hopefully the correct spaces, correct direction, or the right places, let's put it that way. But I think by and large, it's about living a healthy lifestyle. It comes down to
And I think us as women, we are in charge of the kitchen. So it's for us to play a role even more, to start using the diet-related things to change the things that we are already using in our kitchen to make those quick lifestyle changes.
And also, another very important aspect, and we touched on this when we had the motivation talk, is about the mental state. Because remember, the word cancer conjures up many images in one's mind. You suddenly feel everything is a death sentence in your life, just because someone had cancer in your home or in your family. It doesn't have to be that way, The positive attitude is also very important to have that positiveness about you.
Very true.
Not just to simply feel that, look, you know what, I'm just a matter of time before I'm gone. That kind of mindset is
I heard that story about a relative who had breast cancer in the family, and came up in our show when we did that. And then the younger sister, who remembered her sister who passed away from breast cancer, older sister, I think she was in her 40s or 50s, late 50s. And then when she turned 51 or something, like, she all of a sudden had anxiety that she had breast cancer without even a diagnosis because of that.
Yeah. The mind is so powerful,
Wow.
That preconceived notion that, that's it. And I suppose with us in Islam, we understand cure comes Allah, time of death is from the Almighty.
Absolutely.
So we have put our faith in that,
Absolutely. Okay, so quickly, what can we look out for when it comes to the bladder? Because now I'm going to book you already, because there's definitely not enough time. Yeah. If we can have a follow-up show with the bladder regards to smoking, women, lifestyle, both male and female.
Yeah. So I'm hoping when we do the bladder segment, we can focus a little bit on some of the risk factors for bladder cancer. Because it's something very ominous signs. Patients may have frequency, urgency, but of irritability to the bladder. So I think we're going to focus on males and look at the risk factors for bladder cancer. I think that's an important one. Also amongst females that are smoking. And then when it comes to the female side of it, Actually, females probably present more commonly with bladder issues because of things like following childbirth, things like prolapse, incontinence.
Okay.
Very, very big area, you know.
Sure.
So I think that may take us up a whole segment just talking about that.
Yeah.
And then the third area around it, the aspect of the bladder, as it relates to neurological issues. And we sort of, in the break, we're touching on things like multiple sclerosis and other neurological issues, where it also affects the bladder so significantly that in most cases, patients, the bladder rules their life.
Yeah.
Not the other way around, you know.
Very
So I
true.
think if we think about it, those three big areas, you know, males, females, and maybe neurological, I think hopefully we will have covered many concerns that individuals have and issues around those concepts.
Sort of to wrap up, Dr. Salim, I want to look at, because I did, of course, now reading on the bladder, pardon, on the prostate and the cancer and myths and misconceptions. Anything that we should know that is possibly, you know, that we are afraid of not doing and that we can possibly do to prevent or help us with prostate cancer, that there are hidden issues, myths and misconceptions that you can highlight quickly before we wrap up?
So I think, look, there's a lot of things in the media about, you know, certain tablets one can take, certain medication one can take to prevent prostate cancer, what we term is chemoprophylaxis.
Okay.
There hasn't been much scientific proof of that.
Okay.
Patients, a lot of people take a lot of natural products, natural substances. You know, I don't dissuade them from doing that if that's what they want to do, but I never let that replace the medical therapy. We can do both, you know. The other thing also about this thing about prostate cancer, which I've seen in some of the more, I would say, conservative communities, as much as you can present to them all the facts literally in front of them, but they still have this notion that, no, I don't think it's this, you know, I think it's something else. I'm going to do some other form of therapy first, you know. And in most cases, we see those patients.
Are you saying they don't believe their diagnosis?
Yeah, they kind of question it, you know. So I think, you know, as Muslims also, we must also trust the science to it. I'm not saying we must overly trust everything, you know.
Yeah.
Maybe after COVID, people are less trusting of science and whatever it may be, you know.
Yeah.
But by and large, you know, I think if you're sitting with a doctor and he's showing you what's happening to your prostate, that can't be something that the doctors kind of make it up, you know. So that thing about, no, you know, I'm going to go somewhere else, I'm going to do something else. You know, people want to go to like, you know, Hakims or other take other forms of treatment. I have no issue with that. But I'm saying let's not replace one for the other. We can holistically approach it from different angles, you know, and treat it completely. So let's think about, you know what, I can go seek therapy somewhere else and I'll come back and see what happens. We may have missed the boat in that individual, you know. So I think that thing about this little distrust when it comes to Western medicine, you know, I don't see the basis for it, you know, because knowledge is from the Almighty, you know. Doctors out there that are practicing, their knowledge is from the Almighty. And for shows like this are to present that knowledge, which is scientific knowledge, but it's not haram or unlawful, you know.
Very true. And then again, that trusting comes in, and that voice in your head, you know, if it guides you to it, then do it. Something that I almost forgot to do is to check the stats. We spoke about it being common in male African communities. Let's you know, because we have a predominant, quite high viewership of Malawian, Nigerian, you know, Northeast, West Africa viewership. So to speak to them about, you know, the concerns that they have and possibly things that could come up for them and how important it is for them to trust that instinct to go for that necessary screening and PSA.
So that data, that information is from the American, or let's say the Western population. Definitely where they've shown a higher incidence amongst the African American population. If we extrapolate that into our black communities in South Africa, you know, I can't give you exact numbers, but anecdotally from my own practice, I can tell you, if I see a black individual sitting in front of me for someone from the black community, and they've got a bit of an elevated PSA, there's a high chance that it's going to be cancer.
Serious.
Like, so there is that kind of predilection or that kind of, you know, bias towards the black community, definitely, you know. So, you know, again, it's about information. You know, if you know you have a family history or you're from a little bit of a high risk group, then you want to be a little bit more aware. You don't become paranoid, but be aware and maybe, you know, sort of link yourself up to a medical facility quicker or sooner and have a baseline check. Again, the concept of screening, you know, because you're going to come back and say, okay, your PSA is 1 or 1.5. Okay, fine, we don't have to worry about you. You know what I'm saying? But at least you're proactive enough, you know. So I think that message is true, you know, that definitely amongst the black community, there probably is a higher incidence. I don't have any South African data to give you, but just extrapolating from the Western information and my own anecdotal experience in my own practice, I would agree with that.
There's some questions also around the causes of prostate cancer, and we know the genetics and the predisposed individuals. But when it comes to, you know, your lifestyle, the things that you use, the toxic, I don't know, ingredients in some products people are, you know, raving about to stay away from. Is there anything specific with regards to your daily intake or usage of products and foods that one can be aware of?
To my knowledge, I can't give you any specific element or product that may trigger that, but I mentioned earlier about obesity. So living an unhealthy lifestyle, because obesity is shown to create a lot of inflammation in an individual's body, and it has some pro sort of carcinogenic effects. So that's an area that definitely, you know, there's a lot of work in it, but not only for prostate cancer, any cancer. Yeah.
Okay.
So I think a healthy lifestyle is very, very important, you know.
All right. And then just safe websites, information, medical of journals and stuff that people can get more information.
So obviously
about
things like the South African Urological Association, SAUA, even the IMA, you know, if you link yourself to the IMA, you're going to be directed to the correct specialty. We've got that facility available, you know, online as well.
Great stuff. Dr. Salim, our time is up and looking forward to our next show. We just have to pencil a date in because it will be bladder and anything related male and female, so not just male Movember, men's health specifically, but shukran again for your time. Really appreciate it. Learned a lot. All the best. Chat again. Assalamu alaikum. So there we have it, Dr. Salim Choonara. Please note that any questions, comments and queries, you can direct it to our various websites and our email as well as our WhatsApp line. We'll try and channel it through to him as well if you have any additional questions and comments. Stay tuned to our next show as we interview and profile Wheel to Heal and their exciting campaign they'll be launching in December. Again, cancer, the awareness of cancer, that will be highlighted as well. I did an interview, we'll be doing an interview with Dr. Ilyas Parker in next week's show. But all the best until we chat again. Stay tuned to Health and Wellness and the various informative shows on Hilaal TV. Wassalamu alaikum and goodbye for now.